let us read about blunt trauma. Although blunt chest trauma is more common, it is often difficult to identify the extent of the damage because the symptoms may be generalized and vague. In addition, patients may not seek immediate medical attention, which may complicate the problem. Pathophysiology. Injuries to the chest are often life threatening and result in one or more of the following pathologic mechanisms. A. Hypoxemia from disruption of the airway, injury to the lung parenchyma, rib cage, and respiratory musculature. Massive hemorrhage, collapsed lung, and pneumothorax. B. Hypovolemia from massive fluid loss from the great vessels, cardiac rupture, or hemothorax. C. Cardiac failure from cardiac tamponade, cardiac contusion, or increased intrathoracic pressure. These mechanisms frequently result in impaired ventilation and perfusion, leading to ARF, hypovolemic shock, and death. Assessment and diagnostic findings. Time is critical in treating chest trauma. Therefore, it is essential to assess the patient immediately to determine the following: when the injury occurred, mechanism of injury, level of responsiveness, specific injuries, estimated blood loss, recent drug or alcohol use, pre-hospital treatment. The initial assessment of thoracic injuries includes assessment of the patient for airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax, fly chest, and cardiac tamponade. These injuries are life-threatening and need immediate treatment. Secondary assessment would include simple pneumothorax, hemothorax, pulmonary contusion, traumatic aortic rupture, tracheobronchial disruption, esophageal perforation, traumatic diaphragmatic injury, and penetrating wounds to the mediastinum. Although listed as secondary, these injuries may be life-threatening as well developing depending upon the circumstances. The physical examination includes inspection of the airway, thorax, neck veins, and breathing difficulty. Specifics include assessing the rate and depth of breathing for abnormalities such as stridor, cyanosis, nasal flaring, use of accessory muscles, drooling, and overt trauma to the face, mouth, or neck. The chest should be assessed for symmetric movement, symmetry of breath sounds, open chest wounds, entrance of or exit wounds, impaled objects, tracheal shift, distended neck veins, subcutaneous emphysema, and paradoxical chest wall motion. In addition, the chest wall should be assessed for bruising, petechiae, lacerations, and burns. The vital signs and skin color are assessed for signs of shock. The thorax is palpated for tenderness and crepitus. The position of the trachea is also assessed. The initial diagnostic workup includes a chest X-ray, CT scan, complete blood count, clotting studies, type and cross match, electrolytes, oxygen saturation, arterial blood gas analysis, and ECG. The patient is completely undressed to avoid missing additional injuries that can complicate care. Many patients with injuries involving the chest have associated head and abdominal injuries that require attention. Ongoing assessment is essential to monitor the patient's response to treatment and to detect early signs of clinical deterioration. Medical management. The goals of treatment are to evaluate the patient's condition and to initiate aggressive resuscitation. An airway is immediately established with oxygen support and in some cases intubation and ventilatory support. Re-establishing fluid volume and negative intrapleural pressure and draining intrapleural fluid and blood are essential. The potential for massive blood loss and exsanguination with blunt or penetrating chest injuries is high because of injury to the great blood vessels. Many patients die at the scene or in shock by the time help arrives. Agitation and irrational and combative behavior are signs of decreased oxygen delivery to the cerebral cortex. Strategies to restore and maintain cardiopulmonary function include ensuring an adequate airway and ventilation, stabilizing and re-establishing chest wall integrity, occluding any opening into the chest, open pneumothorax, and draining or removing any air or fluid from the thorax to relieve pneumothorax. Hemothorax or cardiac tamponade, hypovolemia, and low cardiac output must be corrected. Many of these treatment efforts, along with the control of hemorrhage, are usually carried out simultaneously at the scene of the injury or in the emergency department. Depending on the success of efforts to control the hemorrhage in the emergency department, the patient may be taken immediately to the operating room. Thank you.